problematic subject, which is esophageal atresia and tracheomalacia. And we have the great pleasure of welcoming the IPEC president, Todd Ponsky, and a wonderful team from Cincinnati Children who are stars in pediatric surgery to talk to us about experience and recent updates in the management of this difficult problem. So welcome, Todd, and welcome to the Cincinnati team. They will be shortly introduced by WOFAPS president-elect. If we talk about their impressive CVs, we'll consume all time. So we'll have a short introduction by Alp about the speakers. And then what's nice about this team is that not only an updated information and guidelines, but they have a special way of lecturing. There's a very attractive team, and this we are all looking forward to listen, and we're waiting for you to discuss in the chat room. Put your questions and comments, and the team will be very happy to answer your questions. Welcome, Todd, and welcome, Cincinnati team. And I'll please introduce our distinguished guest.
Thank you very much, Sameh. And as Sameh mentioned, going through their series, it's very impressive, and I don't want to take certainly the whole hour introducing them, but very briefly, they all have very strong Cincinnati Children's Hospital Medical Center connection. Dr. von Allman has been the lead surgeon, the surgeon-in-chief there since 2015, and he has a special interest in oncology, Crohn's disease, and colitis, as well as, of course, endoscopic surgery. Dr. Michael Rutter is originally from New Zealand, but he's also done his training and settled in Cincinnati, and he's a professor of ENT, otolaryngology, and got special interest in airway surgery and management. Todd Ponsky, we are all very familiar. He's presented in our meetings in the past as well. The current IPEC president also has an appointment at the Cincinnati Children's Hospital Medical Center, and he will be both presenting but also helping me with the moderation of this meeting today. Dr. Garrison, I met some years ago. It might have been 15, 16 years ago, and the time is going so quickly, but also from Cincinnati Children's Hospital trained and has interest in anorectal malformations and inflammatory bowel disease, as well as other general surgical conditions, of course. And we are all looking forward to hearing your talk. Thank you very much.
Thank you, Alp. Let me just start off and give some explanation of what's going to happen, and then I'm going to turn things over to Aaron. First of all, it's an incredible honor for us to be invited here. As the world knows, WOFAPS organization is really the premier organization, and for us to be in any way invited is incredibly a big honor. So thank you very much. We are going to have fun. Those of you who have seen this, this is not meant to be just a lecture through. We really want interaction. So we have our slides. We can talk. But if there's questions, we're going to stop and go after those, because we really want to make sure we hit on the things that are most relevant. And if we don't get through every slide, that's fine, because we want to make sure that we hit on all the important points that you all want to talk about. And I'm sure, knowing pediatric surgeons, we won't agree on much. And that's great. So we want to hear your disagreements. Tell us why we're right, why we're wrong. That's good. We like that. So as Alp already mentioned, there's going to be 4 of us presenting here. And we each have our own little spin. I'm the least talented in the group, but the other 3 are the real talent. And they are part of the Aerodigestive Center here at Cincinnati Children's Hospital, which I think there is a picture to show you what happens every week when they meet with about, I don't know, it seems like 20, 30 people that all meet to go over every single case from all over the world to talk about the management. And I've been so impressed since I've been there. And I keep asking them to talk about how they manage these patients with such a big team. So first we have Aaron Garrison, who is our esophageal surgeon, who really is an expert in minimally invasive esophageal surgery. Dan von Allman, who has really helped start this program with Mike Rutter and others years ago. And Dan is really an expert in the complex cases, the ones where wow, these are tough to deal with. That's Dan's specialty when the rest of us get scared. And then Mike Rutter, who I guess we invited, we let him come along. Mike is our ENT specialist who is absolutely superb and really has given us incredible insight into some new advances and innovations and how we can be treating some of these diseases. So, Aaron, I'm going to go ahead and share my screen and you'll start it off. And like I said, interrupt as much as you want. What we don't have here are the other two elements of our team, which is pulmonary and GI. They are also part of this team, but today they're not here. So let me go ahead and share and we're going to get going.
Thanks, Todd, and thanks everyone for the invitation. It really is an honor to be speaking to all of you across the world today. We are just going to really talk about both the routine and complex airway evaluation, specifically with esophageal atresia and tracheomalacia. So next slide, please. Dr. Rutter does have some disclosures if he wants to discuss.
I work with various companies. I've got a stent with my name on it that I declined royalties on. There's a patent for an airway balloon, stuff like that. It doesn't affect this talk too much.
And Dan and I have very few. Dan is on the Boulder Surgical Advisory Committee. So again, our goal, we're going to go through a lot of the tips and tricks for both open and thoracoscopic repair. We're going to talk about recurrent fistulas because I think that's a controversial and somewhat stressful thing to discuss, as well as tracheomalacia and vascular compression and what's the evaluation and the ideal treatment for that. If we have time, we can have Dr. Von Allman talk about esophageal replacement, and then our group can finish up with discussing our multidisciplinary team and how we approach some of the more complex issues that we encounter. And as Todd mentioned, we've given this talk a couple times, and really the most fun is when it's interactive and questions in the chat, and push back a little bit if there's something that's said that isn't what you agree with. I always like starting with this slide because esophageal atresia still really has, we haven't exactly fixed this problem or solved this disease. In fact, the lower birth weight and patients with cardiac anomalies really still have a very high mortality in the 70%. So we need to keep thinking about ways to manage this problem. And on the other side, those who are born with isolated esophageal atresia, and they can do quite well and have very high success rates. Next slide, please. We thought we'd start with our first patient who is a term baby. Well-sized baby at 3.5 kilo who starts spitting up with feeds, and then the nurse calls because they tried passing the Repogal and she meets resistance. You can see the picture here, just showing the classic picture of the Repogal in the esophagus not passing down, but importantly there's some air in the GI tract, so that is almost diagnostic of a type C or esophageal atresia with a fistula. The first area of controversy that we talk about is that we have a routine pre-op bronchoscopy, as much as I hate to admit it, best done by our ENT colleagues, such as Dr. Rutter. Mike, why don't you take us through this bronch?
And so if you can just run that video, Todd, thank you. So again, one of the questions, and I think we're going to have a more in-depth discussion on this in a global cast next week, but the question is, what is the value that we bring to the table if you're doing a preoperative bronchoscopy? And we are advocates of doing a preoperative bronchoscopy. It's to identify where the fistula is. Can we cannulate it? Where should you place the tip of an endotracheal tube? Checking how bad their malacia is, because there's always some degree of malacia, checking if they've got a laryngeal cleft. And innately, I think the key here is if you don't look for it, you won't find it. And so it's always worth checking. And frankly, this should be done by whoever's the best at doing it. So whether it's a pediatric surgeon, whether it's a pulmonologist, It's really who's the most capable of dealing with the problem at the time. And that reflects your local culture more than what group you are in, whether you're a pediatric surgeon, whether you're a ENT surgeon or whatever. But that's what we tend to do.
You know, Mike, it's interesting. So far, we've only had a few answers, but it looks like so far everyone here says that's answered that they do always do this. And I've gone back and forth in my career where I started off always doing it, then not doing it. Now I'm back to doing it again. So there we go. So it's a little bit of a mixed bag.
Hey, Mike, can you talk about the exam you do to rule out a cleft? Because I think that that's really important part of why we do this.
And I think that's a reflection of if you want to find it, you've got to look for it. And so typically we actually use a small alligator and actually sort of use it open and push it into that notch. I think there might be a video later on somewhere.
Okay.
But we actually probe the interarytenoid area with a tool, with a little alligator. It's not subtle, it's very quick, and sometimes it looks okay, and the forceps just keep disappearing because it can be surprisingly difficult to diagnose a cleft. It's worth noting that clefts are not well diagnosed with flexible bronchoscopy, and the posterior glottis is best evaluated with a rigid telescope. Pulmonary can do an awful lot of things really well. That is not one of the things that they can do well.
What are you showing here, Mike? Or is this you, Aaron?
I guess this is at the point Dr. Rudder leaves the room and says good luck because
I just sort of drop the mic, leave, you know, run a catheter down one of those holes and say go for it. Yeah.
Right. As somebody mentioned, this is a good way to kind of assess the gap and what the distance is you're going to have to bring the ends of the esophagus together. And the one on the left may look a little more standard, but the one on the right is a clear trifurcation fistula, which can be really challenging to get together. And we have some slides on that scenario later. I did want to talk about thoracoscopy, and I know there are people on the experts on this conference who do this. And I think even though for those who don't do thoracoscopy, there's a lot of good visualization and anatomy and things worth discussing. As Dr. Rothenberg, who did the first thoracoscopic TEF, has kind of popularized, the positioning is very, very important, and really having the patient in a almost prone or semi-prone position is crucial. And I know talking to some friends who try this, if you put them in a more standard right lateral, left lateral decubitus, you're not going to be able to get to the esophagus enough. So they really have to be prone as pictured here. A few more pictures just to emphasize that.
And I just want to restate that the error that I see when I walk into a room of someone who's just getting started doing these is they do a decubitus, and the lung is going to be in the way. So you really almost have to have them close to prone. As Aaron said, it's really a 45-degree thing to drop that lung out of the way, and then your view will be really nice. The whole case can be thrown off if you don't set up right. And the other thing, Aaron, are you going to talk about scope placement? Is that the next?
Why don't you, can your arrow work and sort of show, because that is the next thing. You're absolutely right.
So one of the great things that I learned actually from Steve is that you try to predict where best to put your scope. I usually start off just off the tip of the scapula. But if you go in and it's not perfect, what's really easy to do in a baby is to keep the same skin incision and just move it around to where you want it to be. You really have a lot of flexibility to move that trocar using the same skin incision, a couple of rib spaces different. So don't go through the operation if you don't see it well.
Yeah, great advice. So there's just a couple pictures of you're marking out the scapula, that the camera really posterior tip of the scapula in a typical TEF will be right over where you do your anastomosis, which helps later. One of the great papers that we always review with our fellows as they're getting started was done by Dr. Van der Zee, who really just kind of goes through some of the error traps to look out for. Just remembering that the fistula in the esophagus is in the posterior mediastinum. Sometimes if the ET tube is above the fistula, you can see pulsations of air with the ventilation. Maybe click next, Todd, while we're talking.
All right, you're going to talk about the vagus in the next because I want to hit on that. But
yeah, there's actually a diagram, I think. So just showing the vagus kind of coursing up from the esophagus, which can be kind of like a racing stripe over the esophagus to help identify it, because sometimes it is hard to find.
So I want to again echo that again, just because this saved me. Miguel Gilfan taught me this, that sometimes you get lost and you say, you know, because you don't have necessarily, you just can't find the esophagus. Always look for the vagus. It's your gimme. It's yours. It points it for you. So this stripe here, you follow it, and that will always show you where the esophagus is. Great little trick.
Similarly, when you have a fistula, just it almost can just take you up to where it is, and if you need to get an endo loop around it, you can. Why don't we go next? And then it's just a picture of a nice big juicy vagus there. And again, not everybody has to do direct thoracoscopy. In fact, as I always say, Todd kind of convinced me, because I sort of thought this was a very safe, better operation open. And then as I evolved, I've really appreciated the exposure that you get from the scope and less torquing on the abdominal wall. So go ahead and click start, and we can all chat about it. The first thing we do typically is just kind of get anesthesia on board and comfortable, because we don't use a bronchial blocker. And a lot of times at the beginning of the case, the CO2 will go up, and really just need some constant communication with anesthesia about letting the baby acclimate. We typically do, at least I typically take the azygos vein here, as you see, using the just right sealer or the boulder.
Aaron, I paused because, yeah, I just wanted you to explain what you had in the chest there. So, okay.
Thank you. So the azygos is also a good landmark, and typically we'll start just kind of getting dissected around and sealing with the device.
So that's a 3 millimeter sealer. Okay.
This is after the azygos has been taken, and you can see the vagus and the distal esophagus here. I typically do clip. I know others don't like clips or use different scenarios, suture ligation, but typically we'll do 2 clips on that. And then the part that I think is best with thoracoscopy is dissecting the proximal pouch, and having your anesthesia colleagues put pressure on the repogal so that you can identify it, and really dissecting less traumatically, I think.
So Aaron, do you have something in the proximal pouch to help you?
Yeah, typically a repogal.
Okay.
And you can see that right there. You can kind of get a glimpse that there's some pressure being put on it from above.
Aaron and I have a colleague. Oh, let's talk about this now. So how do you do this part, Aaron?
Well, there's a couple slides on this part, because I think both you and Dr. Von Allman have mentioned to me that, or have emphasized to me that this is actually the most dangerous part, I think, that people may not realize, is that there are attachments of the proximal pouch to the trachea. And it's almost like an anorectal malformation, where you have to make 2 separate walls out of one. And the key, I think, is just staying very close to the esophagus and trying in keeping the surgical fellow or resident out of the trachea.
Yeah, I think that's really important. And I think, so a couple of danger things up there. One is the trachea, as you've mentioned, Aaron. And the key is, if you put a hole in the trachea, the easiest way to fix it is thoracoscopically. So if you get a hole, don't immediately convert to open, because it's typically way up in the apex, and you can just put a stitch in that thoracoscopically. The other thing is you have to be very careful of the recurrent laryngeal nerve and the risk of damaging the recurrent laryngeal nerve with either traction or thermal injury.
So, Aaron, I think you are going to talk about this again, but it's okay to say it twice. This is probably the best point that was taught to me by Sean St. Peter. And a lot of questions are coming in and we'll get to them. Here's how I think of it. If this is the trachea, okay, and you have the distal esophagus and the proximal esophagus like this, we know that the distal esophagus goes in like this, right? It fistulizes like this to the trachea. I actually envision that the proximal does the same, that it doesn't fistulize, but the tip is where it's really stuck to the trachea, not so much back here. So I think what I used to do is go from the tip back, and maybe the others in the room do it that way, but I've switched since Sean St. Peter taught me a trick. I start a little bit back here actually, because it's actually a little looser areolar tissue that you can get into, and I free all this up until I have that tip, and then I take the tip last. This is just the way that I do it because I get really worried about that tip of the proximal esophagus.
Hey, Todd, there are a couple interesting questions in the chat about, and we've talked about these before. And one is, do you actually need to take the azygos vein? And I think that's a really good question. And one of the things I've learned as we started doing thoracoscopic tracheopexies is that the carina is at about the level of the azygos, and you can do much of this without actually taking the azygos vein. I don't know if other people have thoughts about that, but I know that our standard teaching here certainly was that you always take the azygos, and that leads you to the fistula and such. But it's actually probably perfectly reasonable if the anatomy is amenable to not take the azygos.
I think that's a great point, and I've always wanted to see. I always take it, and I always like seeing other people's videos to see. I'd rather not take it. So if there's a really nice way to do it, I always feel like it's in the way, but maybe it's not. Aaron, let me ask you: should we finish this video and then hit all the questions, or you tell me how you want to do this?
Why don't you keep playing it and we can kind of keep talking as we go. The other question I think that was interesting was about 5mm instruments in thoracoscopy, and I think you can use a 5. You're just going to find that it's very long and that the jaw is a lot bigger than it looks in a bigger child or an adult. So you can try it, but I'm not sure you'll be able to get the fine dissection. And this is not a sales pitch for that device or anything. It's just that it's really perfect for this operation, I think.
So and then the other, sorry, we used to use a 5 before we had the 3, and the difference was we had the LS1000, and the LS1000 had these very fine Maryland type tips where you could really dissect. The 5mm energy devices now, other than this, are pretty blunt and very not as great at dissecting. So that's why I think it's also a challenge. And then Aaron, one other point before I play the video. Yama from Japan, Yamataka talks about sometimes not dividing this all the way if you think it's under tension, so that you can put your stitch in while it's still attached and then divide it all the way.
Yeah, I like that idea. I also like potentially using a hitch stitch, like in a duodenal atresia or something. So this one, we do transthoracic stay suture, but I may try Yama's technique next time because I like that idea as well. The other quick thing about the azygos is sometimes it is nice to use that as a pleural flap, just to kind of get some tissue between the fistulas to prevent refistulization or inflammation. And then Dr. Nabil has asked, what about patient position in port sites? I think we showed that you really need to be semi-prone over 45 degrees. And the camera is posterior tip of the scapula looking down right here on the anastomosis. So this would be a case I'm happy with the camera position because the anastomosis is right in the middle. The right hand is really high up in the axilla, in the patient's right axilla. And the left one you can put in last and really just kind of figure out where you feel more comfortable being able to reach up and dissect the proximal pouch, but also help with your anastomosis.
Aaron, Farid Al-Alagi asks, how long do you dissect the distal esophagus? How far down do you go?
I guess as far as you need to get a tension-free anastomosis. So there are times where you have to go all the way down to the diaphragm, and there are times where I feel like you really don't have to go more than maybe halfway. I don't know what others think.
Yeah, I think classic teaching was that you should never mobilize the distal esophagus, but I think that we have become much more aggressive with doing that in order to get length, and that it, you know, the concern is with the blood supply, but we have not found that we have problems with ischemic strictures related to mobilizing the distal esophagus. It's much better if you can get less tension on the anastomosis. So we prefer to do that.
These CT images are from a child who had a TEF repair early in life and had chronic ongoing aspiration and pneumonias. And on further workup, you can see in the top picture, there's almost like a third bronchus there. And that is the residual fistula that was left behind, so a longer fistula. So the other thing we always emphasize is really trying to divide that esophageal fistula flush with the trachea and not leaving a diverticulum, because long term you can get secretions and bacteria that can seed the airway. And the bottom picture shows the air fluid level and a pulmonary abscess there.
Aaron, you want to take questions now or finish these other? I think we hit any. How do you make sure you don't get the recurrent laryngeal?
I think there's a couple things we try to do on the proximal dissection. I think they tend to be more traction injuries up into the neck. So we try to avoid really excessive dissection on that proximal, on the proximal pouch. I don't know if Dr. Rudder has any thoughts on, he may see some of the referral cases first with, or on what causes them.
I mean, the things we see is that the more proximal the fistula, the more likely you are to have a residual pouch, and the more likely you are to end up with a recurrent injury. And the recurrent injury is just as likely to be on the opposite side of your approach, because I think at times you're going a little blind with your dissection. And so, you know, we certainly see traction injuries proximally, and they're often a temporary palsy. But we do have a significant number of kids who've got a unilateral or bilateral vocal cord paralysis that gets sent to us for management.
Yeah, I think I've always been concerned, and when I first started doing these, was using the hook, and there's a lot of concern about thermal spread from that is theoretically reduced with these bipolar type instruments. But I also had a temporary neuropraxia even when using that. So I think certainly traction plays a role, as well as the thing that concerns me more is a more permanent injury from thermal spread. So I think that's multifactorial in terms of the etiology of the nerve damage.
Can I go, could we do rapid fire answers so we can go through these with like maybe just 2-sentence answer, quick answers? Farid Alagi says, he asks, actually, it's a 2-part question because I want to insert something. What do you do preoperatively, Aaron or Dan, if it's a right-sided arch?
Good question. The short answer, I think, is if do what you're more comfortable doing. Lately, I've been going just in the right side, just being more aware of it. And you can typically get posterior to the aorta, which is it just ends up you have to dissect a little more posterior to typical. But others might feel differently.
I agree. And I think oftentimes I think it's been pretty clearly shown that even if it's a right-sided arch, you can fix them from the right side. But we always get a preoperative echo to at least know what we're walking into.
That's a great point, Dan. And that then actually answers his question, which was if you end up missing that, you go in on the right and you see it's a right arch, you would continue on the right side, obviously, because you would even do that if you knew it was there.
Yes.
Okay. Next question was, we already talked about the 3 versus 5. We talked about how far distal to dissect the esophagus. I will tell you, that was another thing I was criticized by Steve when I trained with him 15 years ago, that I was too wimpy on the distal esophagus, that sometimes, you have to go sometimes all the way down to the diaphragm. And so don't be afraid if you need to, but if you don't need to, don't dissect very much. The postoperative NG tube, Aaron's going to talk about. Let's see. What about post-op care? Aaron's going to talk about. What is TAT? I don't know what that is. I don't know if someone could.
I think it taught it Alpia. So I think it's the transanastomotic tube. So just putting a gastric tube through the anastomotic side.
Aaron's going to talk about that. The auto stitch devices are probably too big, Mohammed. I don't think there are any 3 millimeter ones, or even, I don't even know if there's 5 millimeter ones, but there might be. But there are goods we can talk about if we have time, or another time we could talk about the sliding stitch techniques, what to do when it's under tension. It is better to, okay. So there's a lot of other questions, and maybe, Mike, you can sort of answer these. Some of these are for you. So let's keep going.
Well, I did just answer one of them.
Yeah, I saw that. Perfect.
So,
all right, thank you.
We'll ignore that. Shall we just carry on?
Yes. Aaron.
Yeah, I think we touched on this one. So
yep.
Just a few more emphasizing slides on that common wall dangerous part. You can next slide, please. And as Todd mentioned, kind of going above, like where that arrow is where I would maybe start the dissection, or maybe even a little bit higher. Nice picture of the ligated azygos and fistula. And again, as some have mentioned in the chat, using a pleural or azygos flap, any tissue between the suture lines is helpful. So just in summary, whether you're doing it open or with a scope, we typically do a bronchoscopy to characterize and identify the fistula. Others may do extra pleural thoracotomies. And then as far as the transanastomotic feeding tube, I typically have liked them, but our center was involved in some multi-institutional studies with the type C patients, and found that leaving a transanastomotic tube has increased stricture formation. So I really don't know if it's practice changing or not, but we have tended to, in the type C fistulas who were without significant tension, to not leave the transanastomotic feeding tube for that reason. Although if I still do feel more comfortable if it's a long anastomosis, or if there's really a lot of tension. To me, it makes me feel better to leave it behind, but would be curious about what others think.
Yeah, so regarding transanastomotic tubes, last night at APSA, we had a debate about what if there's a duodenal atresia, then I would leave one. I used to leave them all the time. I thought it kept it open. It doesn't. So now I don't. I put it in to do my anastomosis, then take it out. Regarding the chest tubes, I leave them in because I don't want to get called afterwards. But I just make sure it's not pushing on the anastomosis. I want to make sure it's well away from the anastomosis. So.
We talked a little, no retraction or electrocautery up there. You can get to the recurrent laryngeal nerve next. Next, we talked about if that does happen, if you have a tracheal injury thoracoscopically, it is a little bit easier to repair. And then what do you do if you can't get things together? So next slide, please. So this is not our video, but it's a beautiful demonstration of Dr. Vanderzee's group showing thoracoscopic mobilization, and they didn't feel like they could get the ends together primarily. So they did this kind of sliding hitch stitch, almost like an internal Fokker kind of procedure. And I just love this video because it really shows that there's a good amount of tension on there, but they're bringing them together to promote some stretch. And then if you can click the next one, this is, I think, 5 days later. They keep those tacking sutures together, and then they pass this proximal reprogal into the distal esophagus and complete their anastomosis that way. So I just thought that was a really nice technique, because I think I think we do see patients sent here who have tried to have anastomoses when it probably wasn't, there wasn't enough mobility on the ends. And I think you can bail out by open or with a scope, putting them together. Sometimes people will use a silk suture to just try to promote a autofistulization, which I think is another good technique. So I don't think you need to feel badly about not getting them together if in your judgment there's not enough mobility to complete your anastomosis. Great question about if I do prefer passing distal tubes just to make sure there's not a congenital stenosis. I think Todd has had that scenario once before.
Yeah.
So I do think that's a standard part of the procedure. Why don't we just go next? Oh, what we're showing on the left here is that if you are not sure, or if you can leave clips or markers to kind of determine how much distance is between the proximal and the distal pouch, it can be helpful.
And then, so a few questions. Sammy asks, why do we need to remove the tip? I actually don't. I actually just cut and lower the flap. So it's still part of the anastomosis. So I don't cut anything away. But I know we have colleagues, I think Mike Helmerath is one of our colleagues, believes that that tissue is suboptimal tissue because it might have some tracheal type tissue in the tip. So if you remove the tips of both ends, it may be better, but I haven't been convinced yet, so I keep as much as I can. There was another question. Farid Alalagi asked, what are tricks to prevent stricture? I'll let Aaron answer that as well, but I would say that for me, less handling of the esophagus. You know, if you start grabbing it every time you want to put a stitch in, it really gets beat up, and I think that can lead to a stricture. I think leaving a tube, we now know, may cause stricture. When there's tension, that's something you really can't avoid. That's gonna potentially cause a stricture. And I think the most likely cause of a stricture is when there's a leak. So a leak will lead to a stricture. There's a question about Aaron, about time interval between the first and second traction thoracoscopy.
That's a good question. I typically 3 to 5 days, although Dan and I both have similar patients in the NICU, and I'm personally waiting longer. I'm waiting almost a month to go back because my patient's having some other neurosurgical issues and things. So I think it really needs to be individualized to what other conditions the patient has, and whether it's a reoperation already or not. So I think it's patient specific. The last thing I was going to say about the stricture question is I think sometimes there may be people may put in too many sutures, and that may kind of add to it, although I don't know what the right number is. I think my sense is that early on, maybe people tend to just kind of put in more to try to prevent the leak. All right, this is a new, so next case, let's say that a separate baby comes back 2 months after esophageal atresia and fistula repair and starts having more coughing episodes with feeds. Just curious what is on the differential for people, and how would you evaluate the patient in your hospital?
Yeah, so let us know in the chat what you would do with this patient. So 2 months post-op, coughing and trouble with feeding. How do you evaluate them at your hospital? So Aaron, here I'll go. So tell us what you guys do.
So typically we would start with asking Dr. Rudder and ENT colleagues to look, and he'll take us through this bronchoscopy here.
So we may as well just run that video, and we've got the luxury of an aerodigestive team. So typically we would actually have pulmonary, GI, ENT do a triple scope, check that there's not an esophageal stricture, have pulmonary look in the lungs and see if there is either evidence of aspiration or whether they can identify a fistula, and often it's the trick, if you've got a flexible bronchoscope in the trachea, is to put it upside down so you're looking at the back wall. It's just easier. This is where I was talking about using a tool, an alligator, to probe for a cleft, which is what we've just done there. And this child doesn't have a cleft, and their esophagram is very suggestive that they're aspirating probably from a fistula. They've already had a TEF repaired, so now we go in and have a look around. Okay, maybe we don't go in really fast, but we'll get there in the end. So,
and by the way, while we're waiting, a lot of people agree with what okay, go ahead, Mike. What do we see here?
Yeah, well, you can see the old TEF pouch. The question is, has it reconnected? The other thing we're always looking for is the second H-type TEF, and they can be ridiculously hard to find. So high index of suspicion. And so here's one trick for identifying. I'm putting a cuffed endotracheal tube in the upper esophagus. I'm now going to use my telescope in the trachea, and I'm going to get my anesthetist to give me a 30 centimeter positive pressure breath with the cuff of the tube proximal to the pouch, and basically see if air starts blowing through it. And as you can see, air is starting to blow through it. So that is a TEF. It's a very simple, quick, low risk way of doing things. And again, if they have a G tube, vent the G tube. If they don't, make sure to run a suction catheter down into the stomach afterwards. And so that's one of the ways that we try and evaluate. And again, this is just sucking out the pouch. It's quite a big pouch. Now, if you've got a recurrent TEF, these are usually fixable endoscopically. And the key here is that mucosa is a non-stick surface. So you need to remove the mucosa. And whether you use a Bugbee electrocautery or trichloroacetic acid, at the end of the day, that's a tool. The intent is to demucosalize the tract, to get one raw surface against the other. You've got a good chance it'll stick. Be prepared to do it sometimes 2 or 3 times. Often you can get it on one hit. So let's move to the next slide.
Sorry, I think
Is that a second video, Mike, or is that the same one? Hold on.
I think it just keeps playing them. So let's just skip past the next one.
Skip it past it.
This one? Do you want this? No.
This is, I think, showing an H-type.
Yeah, this is worth seeing, actually. So this is a kid who's got a pouch from a previous TEF. We know they're aspirating, but there's nothing in the pouch. And so this is one of those, could they have a second H-type? And this is the index of suspicion, because that pouch looks clean. Ignore the word magnets. This is a Bugbee electrocautery, and it's probing, because I've seen something that makes me suspicious, and it's really subtle. And if you look, suddenly there it is, second H-type TEF. They are more common than the textbooks would have you believe. And these are congenital. This is not a surgical error. And so a lot of these kids, what we found is when we go back and look at the video that we took at the time before the C-type was repaired, and you look critically, you think, damn, I missed it. And they are so easy to miss. So that was the value of that bit of video. Almost invisible. You need a suspicion.
Any questions on the recurrent TEF? Because I will say I'm very happy to have ENT expertise to address these endoscopically, because reoperating on them is a challenge. And I don't know if others have any questions about that.
So Aaron and Mike, several people said kind of what I do, which is if a kid comes in and they're not acting right after the repair, whether they're spitting or whatever, coughing, I start with a contrast study. Do you not do that?
Yes, we do. So usually these kids have already had some sort of esophagram and you've already got an index of suspicion. Typically that's the what's done first. And I guess that I could have put that slightly better. We're just going to do a few quick slides on the other end of TEF recurrence. So this is a 14-year-old girl, actually from Sweden. And she's had a cleft repaired, had a recurrence at the distal end of the cleft, had flaps, tracheal resections, thoracotomies, got a T-tube in place. She's still aspirating a bit to the point that she's got a bit of pulmonary hypertension. Next slide. And so this is with her T-tube in place. And again, as we talked about, some of these TEFs can be incredibly hard to find. So let's take out the T-tube and go looking. And taking out a T-tube is subtle. You just grab it and pull it really hard. And again, some TEFs are easier to find. And so as we go back in, that hole is easy to find because it's very, very big. So esophagus, trachea, and a hole you could put 2 fingers through. And the reason we popped this slide in here is just for the very difficult TEFs. Something that we're literally just publishing at the moment is the value of an operation called a slide tracheoplasty. And this is just checking your cleft repair's intact, which it is. So next slide. Slide tracheoplasty, basically you leave a little bit of trachea attached to the hole and you use that to repair the esophagus, and you slide up the distal trachea and to reunite the trachea. So you're sacrificing a little bit of trachea to fix the hole. Next slide. And my camera wasn't on properly, but you can see the esophageal bougie in the esophagus. That flap is a bit of trachea we're going to use to repair the hole. And so we're just going to sew that flap of trachea over the esophagus. My attention span's extremely short. Next slide. And then we're just repairing the trachea over the top. And so this is using a slide tracheoplasty running suture technique, double arm 4/0 PDS, and you use nerve hooks to slowly pull it all together. It's often remarkable how big a gap you can close doing that technique. And a single running 4/0 double arm PDS on RB2s. Next slide. And this is her 12 months later. They sent me this video from Sweden. And effectively, she's eating, she's drinking, she's got a good airway, got an acceptable voice, and has had no recurrence. So let's move on. That was just a passing. If you've got a really difficult tracheoesophageal fistula, a slide tracheoplasty approach can be of some value.
I think this is shifting gears into tracheomalacia. So let's just go to the next slide because I think we're running a little short on time. Just a couple key points that looking at the dynamic movement of the airway is, I guess, difficult and subjective. There are not really great ways to classify this yet, although others and we are working on this. Tracheomalacia is worse with expiration. I think that's an important thing to remember, that when you're evaluating for it and when both clinically and radiographically. Next slide, please. I know that many have learned that, like, if you have tracheomalacia, typically you will grow out of it. And my sense is that in a lot of the healthier children or larger babies, that is probably true. But some of these with TEFs, it's absolutely not true. And I think that intervening can help them short and long term, trying to avoid some of the consequences of pulmonary hypertension and chronic aspiration and pneumonias. So I will admit it is very difficult to know which children need an operation and which don't. A good example of a more obvious case is one of ours who's 37 weeker who had a chromosomal abnormality and not known to have severe tracheomalacia until we put him to sleep to do a G-tube, and he nearly coded, or he did code and had his procedure canceled. Failed extubation a couple times until his airway was evaluated by our airway team. And they found significant tracheal collapse, so near a 95% tracheal collapse, and then pulsatile compression anteriorly. So again, what is the next step others would take? Please feel free to put in any suggestions in the chat, but we would do an airway eval with, radiographic eval with CT scan. And this is kind of what I was mentioning, the difference between inspiration and expiration visually. And these are about at the same level as you can see from the scapula. But inspiration on the left with the patent diameter airway, and then expiration on the right where there's significant collapse of the trachea. From a ped surgery standpoint, if you could go back one slide, please, Todd. It is important to look at the CT scan and see how much thymus does the baby have, because it can be, you have to have some space to be able to move the aorta anteriorly to provide some positive benefit to the patient. So as you can see on that cross-sectional picture, the airway is essentially closed, and then 2 centimeters or so of thymus, if we move that aorta anteriorly, really will allow it to open up on the anterior aspect. So these are just some, they're actually videos, if you don't mind pushing play, reconstruction images of inspiration and expiration, just to kind of highlight this is the same patient, same imaging, just reconstructed from inspiration and expiration. You can really see dynamically how significant it can be. So we're fortunate that our radiology colleagues can help us with this. So we did want to talk about aortopexy, just a few diagrams showing what the goal is. And again, that is to lift the aorta anteriorly off the airway so that you improve diameter and compliance. Next, please, because I think the videos are a little more fun than the pictures. Next slide. So positioning a little bit different for this one. We typically will approach an aortopexy through the left chest. Most of us do it thoracoscopically. The positioning is reversed though, with a little bump underneath and the arm extended above like this, so that you can get some trocars in the axilla. Next slide. And you can just play these because they're a couple minutes each. So I think we have 5 or 6 steps of the aortopexy, and again, whether open or thoracoscopic, I think the principles are the same. First, starting with the thymectomy, going where it's easy, and just to get space to be able to find the aorta. And again, this is that 3mm device. I think using hook cautery is absolutely okay also. Couple things to watch out for in this operation: the phrenic nerve you can see underneath the device there, kind of coursing along the cava. This is the superior aspect of the thymus, and then many times I would say more times than not, we have to remove about half the thymus gland. There are times though when you can just kind of push it over into the right chest, and you can see some of the veins. Innominate veins superiorly that we can get to. There's a bridging vein there that would be taken with the device as well. So step 1 is the thymectomy. I think this is the last little part of that. And we typically will remove that at the very end. So just kind of put it out of the way and remove it at the end. And now you can see below.
Oh, sorry.
Yeah, no, it's okay.
You were done.
You can see below just the aorta. You can just go to the next one because it picks up there. what we are looking for is the aortic anastomotic junction, which you can see kind of going off into the right chest. So it comes up a little bit. So the arch of the aorta is right under the device right now, and the anastomotic, of course, is up to about 11 or 12 o'clock. And this is the scary part of the operation, elevating the pericardium and using scissors to cut. You can go to the next slide. So we do this for a couple of reasons. One, make sure you're in the right place. And if that were adventitial, it should not be so easy to elevate and lift up. But once you've gotten into the pericardium and you've released that pericardial fluid, you're able to see the anastomotic underneath a little bit better and kind of guide it, find your pathway that you're gonna elevate. And then some techniques are different on this. Some will actually go through the actual wall of the aorta, which I think is okay. It may be a little bit more dangerous. What we've done, instead of just elevating the pericardium, which I think is not as effective, as we kind of split the difference and we'll put our sutures at the pericardial adventitial junction. So that's down at where the pericardium just kind of attaches to the adventitia, and kind of getting a good bite of that tissue so that it's a little more flexible and a little less scary than putting sutures directly into the aorta. And this is a part of the procedure that I wish we had a better way, because it always feels a little bit awkward in a baby. You can see how large that needle looks. And we will then put about 3 sutures in, typically into the adventitia, into the pericardial adventitial junction. This is our first one. And then we'll pass them back out the sternum. In the larger children, we have tacked them underneath the sternum. It just seems a little harder in the babies to kind of get a good apposition. So we now will kind of tie them externally in the subcutaneous tissue.
But Aaron, in that, it looked like you only got a pericardium.
Yeah, so I agree that I need, so this is the first one, and then we kind of put in some others. I would have preferred that we got a little bit lower. So thanks for pointing out my error, Todd.
Yes, that's my job.
But I think
when you say you get, I guess when you say you get the adventitial pericardial junction, if you've separated it off, where is that junction? I guess I don't understand.
It's the pericardium goes from the pericardium up onto the anastomotic, and you can use that as like just a sling almost, without getting the actual aorta or anastomotic vessels. Okay. I know the last time we did this, someone had mentioned that it's easy to pexy the pulmonary artery, which is absolutely true. But I think if you open the pericardium and can see that thick-walled structure, it's easier to identify the difference between that and the pulmonary artery.
I would just make a passing comment that taking out the thymus is key. And if you've got a kid with the George who doesn't have a thymus, an aortopexy isn't going to work very well. And try not to dissect between the aorta and the trachea. You're trying to drag it up with you.
Right.
Yeah, I agree. And that highlights the need for the CT. And so you can see that with that thymus gone, what Dr. Roeder's pointing out, and so you really get a few, at least 3-4 centimeters sometimes of elevation. And so, yeah, I would have preferred maybe a little bit more of a aortic bite there, but this worked out quite well.
I'm just curious from the audience. So I have done almost none of these, and for some reason there's a whole bunch done at certain centers, but when I was in Akron, we did 0, right, Aaron? I mean, when you were there, we didn't do any.
I totally agree. And I think I was actually thinking on the way here this morning, I know of one patient that maybe probably would have benefited from this, but I think taking care of these patients on your own is a lot different than taking care of these patients with your ENT colleagues and with pulmonary, who are like kind of tell you like, no, something's not right. And once our esophagus is together and the patient's breathing better, we kind of think everything's okay. But if they keep having desaturations and respiratory infections, or they're unable to wean off oxygen, then really having a team of people to help guide you in the right direction is I really appreciate. So I think it is not that there's not a lot of children who need it. I think we're just not necessarily looking for it. And I do think that a lot of times babies will grow out of it, but I think they would get better faster with this operation.
Okay. And that's the big debate. And Aaron and Mike, so you do only a Hemi Thymectomy, right?
Yeah.
So
Typically, it's just what's in the way, just take it out.
right. So that's the question around the baby's immunity shouldn't really be affected because they still have the majority of their thymus left. So.
And this is just the post-op endoscopy afterwards, showing less airway collapse. I regret I don't think I put in the pre-op, but I will do that. But you can see from the anterior aspect, there isn't a lot of collapse on this patient. And before it was 95%, if you remember. I think hopefully Dan will be able to join us again, but the harder thing, I think, the anterior aortopexy, anterior tracheomalacia is a little bit more easy to conceptualize in my mind. Posterior is a little more controversial, and many of you are probably familiar with Dr. Jennings, who is one of the pioneers in this field, who has really kind of started doing some of the posterior tracheopexy, and we've taken some of those techniques and changed them a little bit. He believes that most patients need a posterior tracheopexy. However, we recognize his patients are more of a referral base and maybe different, whereas Dr. Rothenberg, another expert, believes few need it and has only did 4 out of his series of 145. Again, we don't have long-term follow-up on that yet.
So just to highlight that, these 2 slides show you the variability in opinion that you have, some centers that believe all or most should get it, and some centers that believe almost nobody should get it. So
Right.
What's the answer? This is classic pediatric surgery.
Right. Dr. Van der Zee, I think we see things similarly, that some children need it, and so just hard to know up front which patients that will be. So I think our next slide might be your video, Todd.
Side, then you should consider doing it. Now in this paper, we described 4 patients we operated.
So let me set this up. This was a paper that was published in the Journal of Pediatric Surgery, that what David and his group do now is that they do, in those who need it, they do it at the time of TEF repair. So they do the tracheopexy at that time. In those, they predict that we'll need it. Now, the controversy is maybe these kids did not need it at all. And are they doing too much? Their point is it's better to do it right there, put a couple extra stitches in, and you don't have to go back in later. So it's very controversial, but this is one of these topics that is very hot over the last few years. So this controversy of something that maybe we weren't doing enough of, these posterior tracheopexies. You see some people think everyone should get it. Some say no one should get it. I think the answer is in the middle, and this is an approach in the Netherlands.
Side, then you should consider doing it. Now in this paper, we described 4 patients we operated last year. They all had moderate to severe tracheomalacia and bronchoscopy, especially posterior membranous intrusion of the lumen. And those patients were operated during Thoracoscopic subtial tracheal surgery. We made apexia of the posterior wall towards the spinal ligament. And then we anastomosed both ends. This is done with non-absorbable sutures. So all patients recovered well, and none of them had any respiratory symptoms after surgery. This technique only takes 6 minutes per suture, and 2 or 3 sutures are placed. So during the thoracoscopic procedure, it doesn't take much extra time to perform. Okay. I just want to make sure I got the summary right. What's being described here is that because it is so prominent in patients with esophageal atresia, instead of having to go back a second time for those patients, you guys do it proactively every time you're going to do an esophageal atresia repair.
So it's they assess every time they're going to do a repair, and then they fix the ones they think may need it. I can tell you that I had 5 or 10 phone calls from Arnie Korn when I released this video, saying that he can't believe that they're doing so many of these. These kids did not need this done. And then the other argument is that, how do you know? They probably did, and we're missing a lot of these cases. So this is a very hot topic.
Yeah, I agree. And I want to emphasize what you said is that going back and doing a posterior tracheopexy after you've already done the operation is a bit miserable. And so if you have evidence of it at the time, consider doing it up front. Similarly, we had a patient of mine, partner of mine who had a patient who they were unable to get the ends of the esophagus together. They decided to do the posterior tracheopexy then, go back later and try to, after some internal tension sutures. And that was a really good move, I think, because didn't have to worry about as much inflammation. So let's go on to the next slide, just kind of saying that we are still working this out. And we really, as Dr. Ritter pointed out in the chat earlier, we go on how is the patient behaving and clinically correlate that to what we see endoscopically. This is just a video Dr. von Allman made of a older child, as you can see from the CT scan, of how we do a thoracoscopic posterior tracheopexy. So unlike the previous two operations, we do these through the right chest. We can also.
Do you want me to play audio, Aaron?
No, there's no audio. You don't need the audio. I'm sorry.
Okay. All right.
This is just opening up the pleura. And this is a patient who did not have an esophageal atresia issue, just more of a unknown idiopathic tracheomalacia, and she was older. So I think one of the key things here is just really, this is the esophagus in the left hand that he's mobilizing, trying to get the separate planes separated and moving the esophagus out of the way so that you can get your sutures from the trachea to the vertebral body right there. So he's pressing on the vertebral bodies with the esophagus starting to get dissected out of the way. Vessel loop going around the esophagus so that it can be retracted out of the way for the suture. Bring up that plane between the two structures a little bit more. This is really kind of cool when we ask our pulmonologist to come in, and so we're looking at the monitor at the same time, endoscopically and thoracoscopically, so they can tell us. We will actually press on the trachea, and they'll say a little bit to the left, a little bit to the right, so that we can be sure that we're getting right in the center of the trachea. There are times where we've seen where if it's off to the side a little too much, the airway lumen can be compromised. So we really try to put it in the center and confirm both pre and post-op that we've made a difference from the airway caliber standpoint.
Just curious if anyone in the audience has done this. I haven't done one yet.
I think one of the fixing the airway posteriorly, I think helps, but for some reason moving that esophagus out of the way, I think maybe one of the more beneficial components of it. But we are absolutely still learning about this and what ways to make it better. But in the right patients, it has helped a lot.
Yeah.
Go to the next slide. I don't know how much more time we've got.
Well, that's what I wanted to ask you. You know the rest of the talk. Do you want to leave 10 minutes for Q&A, or do you want to go through some final important slides?
I think maybe there's a couple slides and then we can stop before esophageal replacement. Maybe Dr. Rutter, do you want to talk about just tracheomalacia and assessing it and how variable it can be?
I've got to tell you, I wish we had an answer to this, and we simply don't. We've got some kids who you scope them, you bronch them, and they've got appalling malacia, and they're 10, they're 15, they've had a TEF in the distant past, and they're completely asymptomatic. We've got some other kids who, when you scope them, if they're deeply anesthetized, it really looks absolutely normal. And then if you get them very light, breathing hard, you see a lot of collapse. I think the key really is it's symptomatically based. I think the most important thing is that if the child doesn't have symptoms, don't treat what you see on a telescope. If they've got significant symptoms, apneas, acute life-threatening events, if they're developing extremely sick every winter, being admitted to hospital with every cough or a cold, those are the kids where I think you can do something. But although a lot of people are putting work into diagnostics with tracheomalacia and bronchomalacia, the simple answer is we don't have an answer. If you've got significant bronchomalacia past the main stem bronchi, there is not a surgical solution to that. And a lot of these kids do.
Okay.
Just showing pre and post-op symptoms based on aortopexy and treating tracheomalacia. So things like cough get much better. This may be kind of a good time because this just talks about how we all are still working on this, and that one patient we did a posterior tracheopexy on got better quick, just for a short duration of time, and then had recurrent symptoms. And then next slide. Dr. Rudder ended up going in and fixing the fistula fixing the malacia higher up in the neck. So there are still times where localizing it can be difficult. Just kind of, I think, future goals. We do have a NICU MRI scanner, which we've started using, and we're really hoping that this kind of tells us before surgery which kids are going to need this operation. So you can see the proximal pouch in green there, and this is, go back to that go to the next one. I think it's the best one. This is kind of what I was saying, is that this is the pre-op on the left, post-op with that esophagus anastomosed, and you can kind of just see how the airway dynamics are changed just with doing that procedure. So some of them will get better just by putting the esophagus together, but which of those kids left afterwards do we need to really reinforce the posterior wall of the trachea? So just some cool more images and things that may guide our techniques in the future.
So let's stop at esophageal replacement and open it up. I guess Alp or Sammy, I don't know if we can unmute people or how that works, or someone wants to raise their hand and ask a question, or we could just do chat.
I think they will just type the questions in the chat box for us if they can, and then we can try to answer them. And I think it's already been fantastic. You've touched too many points that's already been raised during the talk. And I'm also conscious about the time that you all have very busy days ahead, but we can certainly try to answer some pressing questions that's been put onto the chat for us.
The question about how often do kids end up needing an anti-reflux procedure? I don't know the percentage. I will tell you that it for me used to be higher. I used to do anti-reflux procedures all the time, and I do them much less frequently now. I think the pendulum swings back and forth.
I think the longer gap kids may be more likely to need them. So maybe 50% or so, I'd say, of those, but maybe 25. This is just ballparking, 25% of the others. But I agree, it's much less common. One of the other questions I think was sent pre-op or pre-presentation was about anti-reflux medication and how long. And we use guidelines that were developed in 2016. So all of our esophageal atresia babies are on a PPI for 1 year. And then at 1 year, we reassess whether they need to continue it or not. But obviously, they do need long-term surveillance for reflux, and as they get older, for Barrett's and esophagitis and things like that.
says, a lot of these you guys have already answered in the chat. So what I would say is if we didn't get to your question from above, just go ahead and ask it again. And then Alp, I'll leave it to you. Other than that, we could always end early.
Thank you very much. Yeah, so also perhaps I can just ask all three of you, I'm sorry that Dan, I think, had to leave. Is there any final comments that you would like to make? Things have changed certainly from the time that we've started pediatric surgery going into the thoracoscopy route more and more endoscopic surgery coming in place. And perhaps we can just have your final comments from Aaron, from Mike, and from Todd, and then I'll ask Sameh to close the session for us.
I'm going to make two comments. So the first is that as time goes by, the value of a team approach where it's not just one person or one service caring for a child, I think is really starting to become apparent to all of us. And so the aerodigestive concept is great. It's not always achievable and it depends on your individual circumstances. But I think we do much better as a team than we do as a group of individuals. The second comment is that Naked Advert, we're having a conference in October of 2022 in Cincinnati, combining INOIA, which is the esophageal atresia group, with the next Cincinnati Airway course and the aerodigestive meeting. We're combining all of those together. So if you want to visit Cincinnati, it's a really exciting place, October 2022.
Yeah, just to add on that, I think having worked in a hospital where I didn't have the multidisciplinary team, it really is a team approach. And if you're not sure, ask a friend for help. I think if you feel like something is not right, evaluating endoscopically, and if that's not best done in your hands, then sending to someone who can help. Yeah, just really having a team approach, but recognizing that not everybody has that luxury. So, we're here and happy to answer any questions if we can.
Yeah. So first of all, thank you for having this webinar. I think esophageal atresia is one of these things that it's one of the ones we're really not great at. That and appendicitis, we still haven't figured it out completely yet. And it's tough. It's still really tough. And there's the high complication rate. And I think the answer, Alp, you mentioned, yes, we're getting better at like minimally invasive techniques. I saw someone mention magnets, and I know Aaron and Mike have had experience with using the flourish magnet technique. But I think the solution will not be surgical. I look at stuff that people like our colleague Mike Helmrath is doing, where he's creating esophagus in the lab, and he's very close to announcing that very soon. I think that there are going to be novel therapies that are not going to just be stretching things together, but more in the lab invention. So there's a lot to come with this. We have a lot to learn, and this is where we're at right now. And I am very thankful to Mike and Aaron and Dan, who had to run, but to tell us about what they're doing with this team. So thank you again very much for having us on this webinar.
Thank you very much. Sameh, I'll hand it over to you. Thank you.
Thank you so much. If we measure the success of any online meeting by the amount of interaction, if you look at the chat area, you'll see that this was an outstanding meeting. The crowd were very much excited, with shooting a lot of very interesting questions. We had a huge crowd today. And if you look at the file, it's a huge file of interaction. I think this needs to be saved and looked again another time. I would like to thank very much Todd, Aaron, Mike, and Dan for an outstanding online meeting. And I'm sure that after the permission of the speakers, the session has been recorded, and a lot of people would love to watch it again. It is a great collaboration between the WOFAPS and the IPEC and Cincinnati Children. I'm sure that the next time, we hope that will be a physical meeting where we can shake hands and drink coffee together. But we truly enjoyed this outstanding, exceptional meeting. Not only the amount of science, but truly the way of delivery has been outstanding. It will be available for the IPEC for Cincinnati. We'll send the recording. I would like to thank Alp for moderating this exceptional session and the whole technical team of the WOFAPS. I would like to invite you all to visit the WOFAPS website, and you can become individual members. This is a new feature of the WOFAPS. Todd, Mike, and all friends are invited to become individual members of the WOFAPS for a very small nominal yearly dues, but it will give you a lot of advantage. You will follow our activities. You can get our educational links and videos very easily. Thank you again for the great presentation, for the audience interaction, and stay tuned with the WOFAPS for our next meeting. Stay safe, and thank you so much.
Thank you.
Thank you.
Thank you so much.